Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the podcast. We are here in Raleigh, North Carolina, for the SOMA conference, Special Operations Medical Association conference. Today, I am talking with Tom and Ella, who are on our faculty, and they are here for the first time at the conference. And can you introduce yourselves and say why you're here?
Hi, I'm Ella. I'm a GP or family medicine doctor in the north of Scotland on one of the Outer Hebrides Islands, and I also work in A&E emergency medicine in the Scottish Highlands mainland.
Hi, I'm Tom. I'm the Year 2 lead on the CoROM Bachelor's Programme, Paramedic Bachelor's Programme. And then clinically, I'm a paramedic and a pre-hospital care doctor and family medicine doctor up in Scotland.
So this is your first time at the SOMA conference. So tell me, why are you here and what did you learn?
So I was suggested to come probably from CoROM running the austere emergency care course, which was guided by Sean Keenan, who is a big fish, would be fair to say, in the special operations medicine world.
He's the next president of SOMA.
So has an interest there, clearly, who recommended that I come over to SOMA, as did you, Aebhric.
Yeah.
And then, to be honest, it took a little bit of convincing because neither Ella nor myself are military or law enforcement. So it seemed like quite a jump. It seemed like something that would not be overly relevant. But then we took a gamble on it and were proved wrong, which is really nice.
And I took a look at the workshops and they looked both interesting and directly relevant, which kind of I found both reassuring, and they looked genuinely very interesting. So that probably was a big persuasive thing for me as well.
So which workshops did you do?
I attended 3 workshops. One was on crike, surgical crike, and then 2 ultrasound sessions. Each of those was a half day. And the ultrasound one was basic ultrasound, albeit not as basic as I might have expected. And then the other was a focus on musculoskeletal ultrasound.
And what were some of the take-home messages, the points?
My favourite, probably unexpectedly, was the crike session. I've had training and opportunities to do moulage and sim in different courses that I've done before. I've done wet sim. And so I wasn't really expecting it to be more than an opportunity to redo that. But I found that the way the session ran, we had a demonstration and a talk about the kind of skills, and then did practice on mannequins, as I've done before, and then practice on a model which a person can wear, and also an opportunity to, check the anatomy on lots and lots of people. And just the sheer number of repetitions we got was completely different to any session I've done before, and let you get opportunity to try different methods, find what works for your hands, positions, tweak the little things rather than just remember the basics of the steps you're going through.
And then actually develop muscle memory, presumably,
Absolutely.
Rather than just do the skill once. Oh yeah, I've done the skill once. Great.
And risk trying things, because normally you're going to get 2 or 3 goes. So you go through the steps methodically. Whereas because I knew I could try another 10 times, I'd say, okay, this time I'm going to try having the bougie preloaded. I'm going to try it without the bougie preloaded. I'm going to try holding my hand in this position. And those small things added up to getting a lot more slick over the course of the session.
And troubleshooting problems on a mannequin rather than when you're at the side of the road and you're like, oh, that didn't go according to plan, or I've dropped my bit of kit, so I'm going to have to improvise and do something slightly different.
Exactly. And the other attendees, majority of them were medics, and several had the opportunity to do surgical crikes in real life, which I haven't. And so it was really nice to hear people's experiences, and many people's experiences of when it hasn't gone perfectly smoothly, and learn from their mistakes, which I guess is the whole point of conferences, really.
Just on a slight surgical airway sidetrack, one of my supervisors for a research project was a really active pre-hospital doctor. And I was chatting to him one day about surgical airways. And I said, oh, look, it's clearly a core skill, etc. And he said, the 2 he'd only done 2 in his career. And they were both people trapped in vehicles in a kind of erect, head up, kind of crushed, smushed position. So neither of them were people lying on the floor with airway compromise.
Mm-hmm.
Wow.
And he was just pointing out, look, this is really rare, but therefore you can't just train for it in the most simple, easy scenario.
Yeah.
Which was
revolutionary.
Talking to someone who's actually done it
Yeah.
and can point out the realism issues.
Yeah. One thing they did in this session, and I guess partly because it's tactical as a focus for some of the attendees, but they had us practice with our model, who was wearing the kind of practice model, wearing body armor. And for the people who are tactical, it's an opportunity to practice when the body armor's stuck, you can't get it off. But actually, more realistically for me, if you've got a patient with a very high BMI and the anatomy is a lot more difficult to evaluate, then it gives you an opportunity to they were using the very basic landmarks of, find the thyroid cartilage, find the sternal notch. Both of those at the wrong place, look in between those as a basic starting point for when your mind's going 100 miles an hour and the anatomy is not easy.
And the techniques, were they doing longitudinal or vertical?
They were doing a longitudinal a vertical incision, part of the skin, and then do a horizontal incision, and were very much pushing for everybody to be doing scalpel, finger, bougie, tube. Some people, because they were working in services that provided them with a pre-made kit that had a hook or had a trocar, were going to have to remain familiar with those techniques, but there was a lot of emphasis on sticking to scalpel, finger, bougie as the...
And nice having a technique that doesn't rely on having a tracheal hook, because if you haven't got one, then your whole muscle memory is gone because you haven't got the key bit of kit.
Yeah.
That's quite nice.
And so they were advocating no tracheal hooks there, and they were advocating something in the hole at all times?
Yes, exactly. And just kind of because there were lots of people there who had experience of doing it practically, for some people several times, just small tweaks like I've previously been taught, scalpel, make your incision, turn it 90 degrees, put your finger in behind it. But actually, realistically, that doesn't give you very much space in your hole. And so they were suggesting specifically turn it so the blade's pointing to the patient's left hip. And by practicing it, so this might be too much detail, but for my horizontal incision, I just got into the rhythm of making my first horizontal incision always towards myself, away from myself, and it's then only a 45-degree turn to point to the left hip, and that gives your finger the maximum space, but also means that you've done a really nice incision, and hopefully that's now in my muscle memory.
And your finger's on the back of the blade instead of the front of the blade. Yeah. And then you had the 2 ultrasounds.
Yeah, so each of the ultrasound sessions were set up so that you rotated through 4 stations, and you had 50 minutes per station, with a different focus on each station. I would say the only limitation or criticism I would have of the sessions was that we were using ourselves as models, which is helpful in some regards because you feel where the probe was. But on the other hand, for some people who were the model for a long time, they missed seeing the screen. In the first session, we covered a small session on musculoskeletal, and then we did echocardiogram with focus for kind of emergency assessments. So looking at an estimate of ejection fraction, for example, checking for effusions. And then we also did rush. And I think our last section of that was procedural skills, with lots of opportunity to practice on models, which was very helpful for me. And then the second session was musculoskeletal, and we went through this focus, again, being tactical, was looking at, for the military attendees, things they might be able to ultrasound that would help determine whether or not their patient could stay in the field or not, or whether it was guaranteed that they needed to leave. So it was identifying fractures, identifying, again, severe cardiac issues, not in the musculoskeletal, identifying shoulder issues, foot and ankle, and then again we looked at procedures and discussed some of the nerve blocks that might be useful.
But then again, so just hearing you talk about it again, can I return this person to a combat role, or do they need to fly off to further investigation? Is so similar to you're seeing a patient 2 hours from the nearest X-ray machine. Do I need to send them down at 11 o'clock at night? Do I need to send them down at all?
Yeah.
It's essentially the same question, just in a different framing. It's
Yeah, and there were other
You know.
attendees. So one of the instructors, in fact, is a primary care physician, same as I am. And we were talking about, and it was nice to have someone there from a similar background, albeit that he's military. And there were clearly times when I would be using this in my clinic if I had the facility to, and he was talking about the way he uses it in his clinic in primary care. And exactly like you say, does this patient need to go, for me, sometimes quite a distance to get to an X-ray? Could they wait until tomorrow, especially if they're elderly and they may be going to need to arrange transport? And then all those kinds of logistical problems, they might be created because of different reasons. But if you're working rurally, you have a lot of the same considerations.
I found that throughout the conference, things like clearly and operationally, logistical issues are massive. Can a helicopter land here? Is it safe? Is it appropriate? Is a completely different logistical issue to, can this elderly lady find a car to take her 2 miles down the road, and how is she going to get home? Like, the logistical issue is different, but they both have the same massive logistical knock-on effect.
Yeah.
So then in terms of the medicine, it suddenly becomes very, very similar.
Yeah, and questions like, is this fracture guaranteed to be an unstable fracture, and actually is letting my patient mobilise because they feel that they're able to, going to do them active harm?
Yeah.
And that's the same question in both of those settings.
And I would argue there's the strong similarity between Scottish farmer, desperate to go back to finish fencing, and a soldier desperate to go back and join the fight or go back on mission.
Yeah.
Like, I would suggest the drive is quite similar with those farmers brushing off wounds and getting back into the field.
Yeah.
So these decision-making processes and the assessment skills you saw are applicable for the civilian austere provider?
Definitely. I think, like we were saying, some of those decisions in primary care about whether your patient needs to go to a different facility, and for a lot of patients, that's not as trivial as just jumping in the car and driving 5 minutes down the road. It might be you need to go to a different island for this facility, or it might be as simple as getting in a car. But on the other hand, you know that there's a 6-hour wait in that department, and I think that's applicable even if you're not rurally, that what you're asking of the patient might be quite a challenge, and if you can make an assessment about how necessary that is, then you're helping your patient.
And we talked before about the benefit of fluid assessment and pulmonary assessment for is this person fluid overloaded or are they fluid deplete? Because often that's quite nuanced, tricky decision. And if you've got that potential dead space of a 3-hour transport time, should you be using that 3 hours to rehydrate them, or should you be using that 3 hours to diurese them?
Yeah.
And point of care ultrasound is a good handheld option for answering that question.
Yeah, that was a section of the first ultrasound session looking at IVC filling, was a skill that I definitely want to take forward and be practicing. And I'm going to be, when I'm in emergency department or pre-hospitally, if there's an opportunity to do so as part of my otherwise continuing my normal assessment, I'm going to start doing that regularly because I want to be able to get my eye in, because I think that's something that would genuinely be practice changing in a way that's massively beneficial for that patient.
So the ultrasound is profoundly beneficial for the 18 Delta or 68 Whiskey, and it's similar to what you guys are doing in Northern Scotland.
Yeah, and I was trying to convince a Scottish mountain rescue doctor the other day to have ultrasound, but I think they haven't had any of the essentially they haven't come to the conferences like this where you see how useful it is, because I think it cognitively is quite a jump of, is it worth carrying this bit of tech onto the hill? And I think you need to talk to other people who are doing it, and clearly operationally there's massive issues on every bit of weight you're carrying is a big issue. Every extra thing in the bag is a big issue, which is the same as a mountain rescue team. You don't want to carry bags that you don't need. So I think there's a huge area for advancing.
Well, I don't have the excuse of deciding whether to carry it up the hill. I'm in an emergency department with an ultrasound.
Or you get someone to carry it for you.
And I get somebody to carry it for me. But without sounding like a dinosaur, I have been very reticent to use ultrasound in my own practice. We have an ultrasound in the department at all times, and it's really the only use I have been using it for has been for occasional difficult vascular access and for fascioiliacal blocks. And I haven't been using it because in my mind, there's been this kind of divide where diagnostic ultrasound is for radiologists and sonographers and people who are cleverer than me. And then I'm just a simple family medicine A&E doctor who can use it for simple procedures, whereas actually doing this course and doing it with a wealth of people of different backgrounds who are already using it in EMS or as medics, and actually showing me that if you learn these specific skills and you don't, you know your own competence and you know your own limitations, but you can use it for that. And if you find something, actually, that's extremely helpful, and it is going to change my practice.
And again, having those other people who are pioneering POCUS or pre-hospital or austere ultrasound that are saying, don't faff around scanning all of these things, but you can do this one test with this question.
Yeah, that's the difference, because sometimes in A&E we'll get a sonographer to come and do an echocardiogram for us when we've got a really difficult question to answer. I've had that happen, and actually that has put me off doing it because I see them doing a full echocardiogram, and I can't do that, but also I don't want to. I want to answer basic questions. I don't want to give my patient a full MOT, and these sessions were focused ultrasound to answer questions that are going to change your management decisions.
So you feel more comfortable with the short axis view and long axis view of the heart?
Definitely, although work needed for the 4-chamber view. I think that's going to be something that I'll continue to have to work on. And, the IVC view isn't the easiest, going from subxiphoid into the IVC view. But it's something that I now feel that if it's not going to delay my patient getting other things, then I will attempt. And also I'm going to carry on doing more training. So I know that the APUS course is coming up and I'm going to attend that.
And as a vague butterfly, was it the butterfly you said could display 2 views at the same time?
Oh, that was
3D, yeah.
It can do. It's got a biplane setting, which I didn't know, which makes me just think of aircraft. But for vascular access, you can get it to show you long and short axis simultaneously, which is just a miracle.
See, I'm jealous that you were shown that, but also in my NHS service that I work for, we have a butterfly.
And no one knew that.
And I never knew that. So I don't know if anyone else knew that.
Well, it's IQ, really cool. IQ Plus.
Oh, okay.
So if you have an IQ older version, you're not going to get that biplane. And the IQ Plus also has a 3D bladder scan.
Oh,
so you can see the entire bladder in 3D. And you can turn it and see the different it's fantastic.
And presumably you might be able to see there's a big clot sitting somewhere.
Yep.
Interesting.
So I pinched that, even though you attended the session.
Yeah.
it gave me good learning. That was good.
Yeah.
So you took 2 ultrasounds and then a surgical airway. Tom, what did you take yesterday?
So yesterday was I was in the Thames track, tactical EMS, right? Yeah. See, I'm down with the lingo. So that was great. It was a good session because it had multiple speakers talking for about half an hour, 20 minutes each. But as always, the problem with that kind of session is you just end up with a notebook full of bullet points for things you need to go and do more reading about. Because you think that was excellent, but now I need to go and do some more reading. Or you think that speaker was excellent, I now need to track down everything they've written because they clearly are experts in the thing they were talking about. So there was some good little nuanced issues there. There was, I wish I had my book so I could tell you who the people were. The snake bite guy was fantastic. My core take home from the snake bite, this is something I didn't know, is so when you get someone with a snake bite injury, you mark, if you can find the puncture wounds, you mark the puncture wounds with a time. That's obvious. I could probably have done that. You mark the level of swelling or redness with a Sharpie and the time. And that's my normal practice. That's fine. But then you also mark a line for pain and a line for tenderness. So for each timestamp, you have swelling, redness, you have pain, and you have tenderness because they are different lines. And you mark them with a time, which gives you a much more nuanced progression of that snakebite injury. So that was fascinating. And then also he did, which I do not do for anything, which is excellent. When treatment was being effective, he would mark the recovery of that with dotted lines for shrinking areas of pain, shrinking areas of tenderness, because then you've got an objective measure rather than, it's better than where it was. You're trending. You're trending it, right? So that was excellent. There was some good encouragement to remove tourniquets and the risk of accidental tourniqueting a swelling limb to the point of, are they lying on their wallet? Are they do they still have body armor on that's compressing somewhere? So that was excellent. And I made a couple of other notes from his session. There was an excellent pediatric session from a pediatric EM doc, which ped sessions always have lots of learning for me. The core take home I got from that was she said, oh, look, most of you in the audience see lots of adult patients and not many peds. So she said, next time you see a significant adult case, when you're having your debrief about that, throw in, so what would we have done if that was a 7-year-old? So when you go to a 20-year-old hit by a car and you've managed them and you've offloaded them to the next level of care, in your debrief you can say, so if that was a 7-year-old, what would we have done? Could we have put that pelvic binder on them? What dose of morphine would we have given them? What was the tranexamic acid dose for an 8-year-old? Do we know where that is? Can we draw it up? What would we have used for access? And I just thought, what a simple way of gaming the system to gain pediatric experience without actually seeing, because we see lots of adults hit by cars. Fortunately, touch wood, we see very few kids hit by cars.
That's fantastic. So each case that you have in a day, then it's also a pediatric case, and it kind of makes that awareness of.
So imagine, you do your normal day, you see 10 adults critically injured, critically unwell, but then in your debrief, you've seen 10 pediatric critically unwell patients. So that was very clever. We had Dr. Claire Park from, I think her affiliation is London Hems still, but she's done the great work on the 10-second triage tool, which is just being rolled out across NHS England. So it was nice hearing her talk about the development behind it, because we'd only seen the final product being rolled out, which is excellent, but really interesting seeing the amount of work they put into that. There were a number of other excellent sessions. There was an FBI session which was part recruitment drive, which, not being eligible to join the FBI, obviously is very disappointing.
You would have done.
Because otherwise, they'd have snapped me up, I assume. But just, fascinating to see that insight into the roles of something like the FBI, because we don't have much interaction with the FBI in the UK, thankfully. So that was yesterday, yeah.
And your workshops?
My workshop, so the main workshop was the full day canine emergencies workshop, which sounded very interesting. So that's why I signed it up. We have working dogs in the Highlands of Scotland where we are. So obviously we have farmers with loads of dogs, which can get injured alongside a farmer. And then we have mountain rescue teams that deploy canines on a pretty regular basis.
Yeah.
And then we have police dogs. So there's that relevance there. And then that session was fantastic. It had appropriate level of didactic teaching. It had live dogs, so we could come in and learn how do you roll a dog onto its side? How do you put a muzzle on a dog? Where do you auscultate a dog? Because that's surprisingly not covered in med school. Where to find pulses on dogs, how to check capillary refill without annoying a dog too much.
Did they talk about tourniquet using the SWAT?
Talked about tourniquets. So their point was no ratchet, no windlass tourniquets at all for a dog, because you can just use elasticated tourniquets.
Yeah.
There was a specific dog tourniquet, which name I can't remember, so I can't product endorse it, but it was excellent. It was really easy to use. And so that was great. And then we had some dog cadavers, which clearly that's not the most pleasant thing. And I would be more at home with cadaver work on humans because I'm a human doctor. But the ability to, we were practicing needle chest decompression on a cadaver. Like that's gold standard training, apart from standing on the shoulder of a veterinarian treating an actual injured dog. This is the next best thing. And then, airway management on an actual dog cadaver, fantastic learning. And then being able to talk to the veterinarians running that session had been involved in the training of, special forces operatives, other various agencies in the US that run dogs often. So they're training the dog handlers and the team medics to a really high standard of canine medicine, which, fantastic to pick their brains about both the actual veterinary medicine, but then also things like the legalities of treating a dog, because in many jurisdictions you're not allowed to do that because that's scope creep against veterinarians. But hopefully everyone can agree that you probably should stop a dog bleeding to death. But where is that? Where's the cutoff? Because once you start giving opiates to a dog and giving tranexamic acid to a dog, that's kind of veterinary medicine. So that was fantastic. Such an expert panel, such a fantastically organised session.
And you said there was good use of VR?
Oh, and there was VR guys who've got a VR training package who have a canine scenario, multiple canine scenarios. So we did a canine scenario in the street, injured dog, and then in a helicopter with an injured dog.
Wow.
And the interface for that VR was excellent, because often it's so clunky, there's no educational value. But they clearly put so much work into it. And again, it gives you that option of running a scenario again and again and again. So that was excellent. And then there was another breakout session in that of, it sounds very basic, of just bandaging dogs, but bandaging dogs is a lot more difficult, or I guess more difficult for me than bandaging a human, because humans generally don't have big floppy ears that you need to strap to their head. And the key take-home point of dogs have 5 limbs because they've got legs and a big tail. So you have to actively think about that. And then how do you bandage a tail? Or which bit of a tail do you tourniquet? So that was excellent.
Wow.
So
you just do a SAM splint in the tail, does it?
You do. They had, so the tip of the tail will just keep bleeding like a fire hose, but not a catastrophic hemorrhage level of bleeding.
All right.
So they were endorsing covering and then taping on a solid cover for the tip of the tail.
Oh.
So like a solid syringe cover case, which we don't really have in the UK, or like a big 60mm syringe with the plunger removed, and then taping that on. And they said it will collect the blood, but if nothing else, it will stop the dog spraying everyone with dog blood. It contains the problem, and then eventually it will clot. But just little things like that, or
no sea-locks into the bottom of the syringe.
Yeah, you can use sea-locks on dogs,
Yeah, okay,
completely fine.
Yeah.
But that was just really interesting. But again, it just raises loads of issues of, I now want to go back to the UK and start asking questions of, how much canine medicine training do your handlers have? And the other issue from that was, if the handler is taken out or is incapacitated, who then is going to manage that working dog? So luckily, Police Scotland have been excellent. I really enjoy working with them, and I hope nothing ever happens to the dog handlers. But some of their dogs are quite intimidating. What if the handler is incapacitated? What's the plan for looking after and controlling their working dog?
Or even getting to the operator. So
Or
the
even
operator's
getting-
down,
Yeah.
the dog's literally on top of them and won't let anyone come close.
Yeah. So again, I think it was a great session because it raises lots of questions. So I've got a notebook with lists of questions, because I work alongside Police Scotland fairly often. And as I said, that it's excellent. I love working alongside them. But I don't want to be in a situation where I can't get to the dog handler because their very well-trained dog is protecting the dog handler. And I don't know what the answer to that is. So now I need to track down someone in Police Scotland who knows the answer to that problem.
And it's one of those things where someone has worked out the best answer to that problem.
Yes.
But a lot of us are going to have to wing it the first time we come across. And it's not, it's tactical situations, but also a patient's dog at an RTC can cause the same issue. And instead of us all winging it, it's so much better if someone else has already worked on the problem and tells you what they do.
If you've already got a plan for those eventualities, which are rare but regular.
Yeah.
Like, we've all been to an RTA where there was a dog in the car, and the driver needs to go to hospital. What do you do with the dog?
Yeah.
And we should have an answer to that ahead of time. So that session was just great. It's probably one of the best conference sessions I've ever been to.
Fantastic.
And it, was an alien concept. Dog medicine isn't something I've done. It was great.
So now that you've had your first SOMA, where do you go from here? Are you going to submit an abstract for next year's SOMA?
I think we need to think about whether there is anything interesting that we have to tell the people at SOMA, because there are some very interesting people here already with a huge wealth of experience.
You keep saying that, and then I hear stories of, oh yeah, it's 25 minutes to get to the casualty, and then I was sitting on the casualty for 4 hours. Hems decided not to come, and then I had to move the casualty. Oh, and I'm working with Police Scotland. Tom, you have every right to present at this conference.
Yeah, maybe my in can be roping in a Police Scotland colleague, and then I won't feel as much that I'm sneaking into a tactical medicine conference.
I think there's other people in Scotland who could bring loads to this conference as well. I mean, it would be great to get some of the small island GPs and island doctors to this conference, because they have got some really, really interesting learning and strategies of dealing with prolonged field care of patients, because they have a patient on an island that has a small hospital that's effectively a nursing home, and they end up looking after a trauma patient for 12, 16, 24 hours because of weather. And that's an experience that a lot of these tactical guys will share, and they'll have different.
And some of those island, they've got excellent protocols in place, because they've been burnt before.
Yeah.
And they got burnt once, and then we're going to solve that problem. This is now our prolonged field care guidance, but they don't call it that.
Yeah.
It would just be the delayed retrieval
book. Or perhaps it's not what you might imagine is austere care, but they've got that very small hospital with one bay that they use as their A&E majors, and they get a sick child for 24 hours, and they've run out of pediatric size cannulas, pediatric size airways. And again, that's kind of shared experiences.
Yeah. Or nappies, or milk, or
absolutely.
All the things that you forget about until they are very important.
Yeah.
Everyone loves to focus on all the cool guy tactical gear and medical gear. Oh, this BVM collapses down into the size of a toothpick, and they're forgetting the nappies.
Yeah.
And the nappies, or I've run out of flush because I put 10 flushes in my prolonged field care bag.
Yeah.
And I used them instantly and dropped half in a ditch.
Yeah.
If you're like me.
So you're heading back tonight. How has this experience, how has SOMA changed your medical practice?
I think something conferences aspire to do is to be inspirational. And I know that's like a little bit of an overly earnest and I don't know, it's a bit embarrassing thing to talk about. But genuinely, the conference has been inspiring. And I think for me, the ultrasound stuff giving me a bit of confidence to set aside my imposter syndrome and embrace it as a skill that I can learn and that will be useful to me has been great. And then it's also just been genuinely really fun, and meeting people who have similar experiences and similar problems that I have, but in a totally different job. And that's been really fun.
Firstly, it was a really enjoyable conference. And I think that's kind of the main thing, right? Because as much as it's education, you should enjoy it as well. I think, so I was only introduced to the prolongedfieldcare.org and the guidelines about a year ago, maybe a year and a half ago. So I've already get on board with that. But having another opportunity to see multiple agencies all using those guidelines and other civilian agencies using those guidelines because they're really good and they're really useful and people have put so much work into them. It's been a nice reinforcement of that's always a good place to go because they might have already answered the question for the problem you're working on. So I think that was good. Loads of the conference sessions raised extra questions for me to go and investigate. So that's what I'm going to take home. I've got loads of notes that I need to go and review. But it's
hopefully
just
we'll be back.
Yeah, so that's the other thing, isn't it? Because it was so welcoming. As civilian medics, you wouldn't necessarily think that a special operations medical conference would be the most comfortable place for us to sit. But I think it was the opposite. I think it's one of the most welcoming conferences.
Yeah, I agree.
And the person you're sitting next to might be an on-the-ground, front-line combat medic, but equally they might be a police officer, non-medical specialist, or they might be the head of a very large organization running their whole medical training. But all of those people have something to learn. All of them have something to talk to you about. And all of them are very welcome.
Yeah, I completely agree.
And it's surprisingly international. Like bumping into, there were some Finns, there were some Germans, there were some other Brits. Norwegians,
Canadians.
of course.
Yeah.
Which was nice. Again, you wouldn't necessarily, or we wouldn't necessarily expect that.
Yeah.
Because we haven't been before. So that was nice. Yeah. Yeah, it's really good.
Fair enough. We look forward to seeing you guys present next year. No pressure. Let's keep saying that. But I feel that your experiences as austere doctors has a place within the Special Operations Medical Association. And I would very much like to see you guys in front of the lecture hall.
Something to work towards, I think.
Well, thanks for coming, and thanks for taking a leap of faith in listening to Sean Keenan and listening to myself suggest this. And I'm glad you guys did it.
Yeah, we're glad too. Yeah, it's great.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is CoROM, CoROM, CoROM.org.